the peripheral low T2 signal makes me think that this could be a cavernoma in the corpus callosum.
Excellent. Excellent. I'll take over because of the time factor. Well done. So you see here, this is a classical exam case. Cavernomas are, have got various kinds of appearances. Cavernomas can occur in this location, which is the geno of the corpus callosum. It is going from one hemisphere to another. Key finding is this hemosiderin rim. If you see this, there is a T2 weighted rim, and which is chronic hemorrhage. Within that, there are foci which are of different signal, as in subacute hemorrhage type of. But that appearance is also known as popcorn appearance. So this is classical for a cavernoma. A complete hemosiderin rim, they say, will not occur in a tumor. So this is a classical cavernoma, and this is an exam case. Okay, this case is your last case, candidate 5. This patient had history of trauma 21 days ago, had a small subdural hematoma on right side, still is having neurological symptoms. A CT scan was done. The hematoma, the subdural hematoma is barely visible, but the patient was not well, and MR was done. What are your findings? Now here the subdural is visible. This is an SWI sequence. What are your findings now?
Okay, so there is a low signal lesion in the, I think it's the left frontal lobe. There's also prominence of the left lateral ventricle. That may be related to the way the slices are taken. There's also another small focus of high signal in the superior right frontal lobe.
Okay, so we can see this low signal here, maybe here, another one here, another one here. With this history, what is your diagnosis?
I think in the context of trauma, could these be small traumatic microhemorrhages?
So what is which kind of history the patient had, which can explain the symptoms also, neurology? These hemorrhages or microhemorrhages are at the gray-white matter junction. That is the hint.
So a diffuse axonal injury type picture.
Excellent, excellent. So thank you, candidate 5. So this is the use of SWI sequence to diagnose diffuse axonal injury. We'll cover diffuse axonal injury later on. But having said that, please remember that this is one of the primary brain injuries. Only 2 types of injuries can occur at the time of the trauma. Parenchymal injuries can occur. One is known as contusion, and second is diffuse axonal injury. Usually, on a CT scan, we don't see it, and clinically speaking, the patient might be much worse off. Diffuse axonal injuries, you have to know that they are at a particular location. What is the location? By the way, the list is more than what I am telling you, but the 4 most common locations are gray-white matter junction, corpus callosum, internal capsule, midbrain. But there can be others also. And you have to see, petechial hemorrhages on a CT scan. But diffuse axonal injury usually is not diagnosed on CT scan, do an MR, you do it. Now, this case, I am just showing you for interest, and I'm not going to teach you. I believe it's a bit beyond FRCR 2B. A theoretical question can arise is about SWI sequence, where please remember, compounds causing susceptibility include All of these things, hemorrhage, as well as iron, as well as hemosiderin, deoxyhemoglobin is acute hemorrhage, minerals, and calcification. So the question is, can we differentiate between calcification and hemorrhage on SWI sequence? And the answer is yes. A poor man method, by the way, is that in your day-to-day practice, you simply see the CT scan. If there is calcification, you call it calcification. But you have to do this filtered phase image. A bit of physics is involved. When you do an SWI sequence, you can post-process them into various kinds of sequences: magnitude, filtered phase, SWI, combined post-processed magnitude and phase, and SWI minimum intensity projection. Out of this, filtered phase will give you this kind of an image. And basically, you have to develop your eyes on your own scanner because it's very complex. Physics is complex, and then windowing and inversion of images and things like that. That is why I say it is beyond FRCR 2B. But if the examiner asks you, at least you should know this theoretical answer, that yes, a filtered phase image can be used to differentiate between calcification and hemorrhage on a susceptibility weighted image. And in the same breath, but there are many pitfalls also. Another take-home point is that on susceptibility weighted image, deoxyhemoglobin, which is an acute hemorrhage which occurs only after 1 day, deoxy can be picked up. So you can pick up 1 day old hemorrhages. Okay, we stop here, and next will be we'll take a 5-minute break, and then we'll go to candidate number 6 after the break. And I can see.
Yes, sir.
Okay, you are there.
Yeah.
So this case, I'm just going to tackle it myself. Sometimes what happens is that there is a condition, we call it siderosis, where what happens is that when a patient has got chronic subarachnoid hemorrhage, maybe post-traumatic at times because of vascular malformations, or even at times tumors, then this goes and deposits on the leptomeninges, and when it gets deposited on the leptomeninges, usually in the basal cistern, around cerebellum, bones, etc., and in this case also on the spine, and you can see how it is low signal on T2 weighted sequence. And another case here is where you can see on this SWI sequence all of this deposited there. The problem is that this is quite neurotoxic, and it gets deposited on the cranial nerves also. For example, the 8 nerves which are in the basal cisterns, and the patient will present to you with deafness, etc. So the point is that I just wanted to show you another use of the SWI sequence. We call it superficial siderosis, and this has now been included in the Chapman superficial siderosis. And so, previous subarachnoid hemorrhage is something which, if you remember this is enough, which can be due to vascular malformation, CNS tumors, etc. Okay, this is a case in which patient presented with hemorrhage, subarachnoid hemorrhage, 6 days ago. After 6 days, CT was done, and this flare sequence of MR was also done. What are your findings? How do you explain this? Over to candidate 6.
So I can see the non-contrast axial CTs, but I can't see any acute intracranial bleed or subarachnoid blood. Looking through the flare sequences on the third and fourth images, I can see there's some high flare signal in the subarachnoid space and in the central sulcus on the fourth slice. But I've got no other sequences to correlate. But
so how do you explain this finding on the flare? What is your interpretation of this finding?
So I'm suspicious of a but I can't see any concurrent finding on the CT to explain this could be subarachnoid blood, because I should be seeing it on the CT at the same site as well, which I'm not.
So how will you tackle this case? Let me warn you that the scenario is slightly atypical, but this film is an exam film. The scenario is atypical, and you have to understand, once you pick up this finding, what can be the causes. Indirectly, I'm asking, if you pick up high signal within the sulci on a flare, what can be the causes?
Subarachnoid would be my top differential, but because I've got the CT head from the same day, but it might be because I'm not seeing it because it's day 6, it's not acute, so I'm not seeing the subarachnoid blood on the CT, whereas for this day 6 or for a flare, for blood on a flare should be bright.
Right. Okay, so the point is that this is from your Chapman, sulcal flare hyperintensity. And hyperintensity means, on a flare sequence, basically, please remember that the CSF has to be, black. And then you get this high signal. So something is abnormal. Subarachnoid hemorrhage is one of the differential. In this particular case, the explanation is that there was a bit of subarachnoid, which is no more visible because it is 6 days old and it is a bit diluted. Having said that, other things which can leptomeningeal carcinomatosis or any infective process can also cause this, and you have to remember this. And if you pick it up, then you give contrast to rule out any enhancement. And so, for example, this was a CT scan where you can see, this subarachnoid, which is high signal on flare. But look at this case. This case, on a T1 weighted sequence, there is no enhancement, but on a post-contrast sequence, you can see this enhancement. And if you look at the flare, you can see this high signal, just like the previous case, which I was showing you. And actually, this was a case of esophageal carcinoma. And with this finding, what will be your conclusion, candidate 6?
So with this finding, it would be phacomeningeal carcinomatosis.
Leptomeningeal means,
So means
it goes gyriform or, along the folia. So it has to be leptomeningeal, right? So please remember, the main thing which we were learning here is high signal on the flare. So this is, once you pick it up, you give contrast, and if it enhances, your differential has to be something bad, infection or tumor carcinomatosis. Okay, the final differential diagnosis of this is this one. So what is happening? There is a tumor in the ventricle. It is sitting within the ventricle, this tumor. What is this signal where I am pointing out this bright signal?
So the bright signal on the flare stays bright.
Is it flare?
No, sorry, on the T1 is bright, on the T1 axial that you've got the pointer on. And then image next to it is a T1 coronal. And so it's bright on T1. So my differentials for bright on T1 would be subacute, early subacute blood, fat, mucin. But this doesn't look like a lipoma. This looks like a tumor with some blood products in it.
Okay, so you're fine. It is a tumor with something inside, but it is not blood product. It is not fat. What else can it be?
Melanin?
Good thought, but no is the answer.
So bright on T1 is fat, melanin, mucin, blood. Those are the four I know of.
Okay, so the idea was, do you see the CT scan?
Yeah.
So what is the answer now? Calcification.
Okay.
Are you with me?
Yeah, yeah.
So the teaching point here is that there is a particular type of calcification which can be high signal on T1. So this is the list from your latest edition, and everything which you pointed out is fine. Fat, methemoglobin, proteinaceous matter, melanin, minerals. Calcification is what I was trying to show you. So please do not think that all kinds of calcification will be bright on T1, but the only thing to remember is that some types of calcification can be bright on T1. This is another case. In this case, there was what we call a burnt out AVM. Burnt out is partially calcified. And on susceptibility weighted image, there is a signal loss here. And correlating with this finding, you can see that portion of it is bright. So that was the point to remember on this. You might have seen FOX calcification so often on a CT scan. And point to remember is that at times that can also be bright on T1 weighted sequence. You see this T1 and it is bright. So, and sometimes calcification can be very tricky. This one is high in signal intensity on T1 as well as T2 weighted sequence. If you see here, this is bright on T1 and bright on T2. You don't have to, should I say, your confidence should not be shattered. Calcification usually is low signal on T1 and T2 weighted sequence. But the point to remember is that at times it can be bright on T1 weighted sequence. This is your last case, and then candidate 7 should be ready. Candidate 6, what is it? Which sequence is this?
So on the top, I've got a axial slices of a T1 with contrast. And on the sagittals, I've again got T1.
Okay, candidate 6. Is this with contrast? Hint. Question mark.
No, I think it's a pattern of a disease. It's not contrast.
Yeah, if you see nothing is enhancing, pituitary, nasal mucosa, no vessels, no nothing. So the point is it was not enhancing.
So I've got I can see there's a disease pattern mainly involves so it's going through the gyri, and it's a gyriform pattern, a high intensity. And
Let me give you a hint. It's sitting in the subarachnoid spaces.
So again, this could be blood.
Blood will never be, the intensity, a 3-day-old subarachnoid will never survive like this, So, no, because it will be very diluted by that time.
This could be calcification.
No. So now you know the answer. This is now I had hidden part of the findings on those sequences. Now I've added that part. Now what is your diagnosis then?
So we've got an extra-axial Brighton T1 with some low signal intensity within it. Looks like fat to me.
So conclusion.
A lipoma?
How do you
dermoid, sorry, a dermoid.
And what has happened to the dermoid?
So it has ruptured.
Yes. Okay. You can mute yourself, candidate 7, to be ready. Let me tell you the teaching points. Now, the point is here, I just selected some images just for you to stretch your imagination. I had not shown you everything intentionally. Ruptured dermoid, if you see here, this is a ruptured dermoid. So on this is fat and a fat saturated sequence. It shows signal dropout. Please remember, how do you differentiate a lipoma from a dermoid? Pathology gives you radiology. Lipoma is all fat. It will be 100% fatty signal. Lipomas are considered choristoma, as in a hematoma, just like a hematoma in the chest. So it's a normal tissue at an abnormal location. Dermoid also, on the other hand, pathologically speaking, dermoid will have multiple layers, dermis and subcutaneous fat and all those things. So the signal will be slightly heterogeneous. It will not be absolute homogeneous fat. Just like our case, there is something else also sitting in. Please remember the concept that dermoids enlarge. They are not neoplasia, but because they are, genetically tuned to grow. So, and that is why they can rupture. When they rupture, now ruptured dermoid is an extremely important exam case. It has come in the exam many a times. And please remember, the dermoid might be sitting in the brain and the dermoid might be sitting in the spine. So they will show you a CT scan in which there will be fat within the CSF, and you have to do your densitometry where it will be lower signal than CSF. I've got cases I'll show you later on. And then the examiner, because on the CT you will not see anything, then the question will be what you will do next. Actually, you should yourself ask that I will like to scan or I'll like to see the images of the spine. And there will be the ruptured dermoid sitting. So please also remember that ruptured dermoid is such a condition that it causes chemical meningitis, and 30% is the mortality. This is where a benign condition can kill a young person. So this is a ruptured dermoid. Now this is a lipoma, and this lipoma is sitting around the corpus callosum. The idea was just to show you this high signal on T1 weighted sequence. So lipoma of the corpus callosum, particularly with agenesis of corpus callosum, that also comes in the exam. Particularly, they might start with a CT scan, axial slice, and then take it further. So I'll show you cases later on. This is a lipoma which is sitting in the quadrigeminal system posterior to the midbrain. So just wanted to show you that, you might pick it up. You might see a lipoma sitting in the suprasellar system. Just call it, and it is of no significance. But if there are heterogeneous signal within a lesion, consider it a dermoid. Dermoids are more commonly in the midline. Okay, candidate 7, are you with us?
Yes.
Okay, now candidate 7. If you see here, this is a T1 weighted sequence. This is a post-contrast T1. This is a T2 weighted sequence. Now, what is this, which is also seen here? How will you
This
call it?
is sphenoid sinus mucosal, as it's written.
Excellent, well done. So this is a sphenoid sinus mucosal. If you see the sphenoid sinus is expanded, and because of high proteinaceous content, it is high signal on T1 weighted sequence. Please remember the list in which, in the list of high signal, the proteinaceous material. Similarly, high signal can be in things like colloid, cyst, etc. Last case, because this was referred by a dermatologist, so you cannot make a diagnosis just on this basis, but how will you describe it?
There is T1, initially hyperintense intraaxial lesions noted at the both cerebral hemispheres. Since it's referred by dermatologist, I could consider melanoma metastasis.
Okay, so it can be melanomas, it can be, one can argue that it might be hemorrhagic metastasis. And what happens is that within hemorrhagic metastasis, there can be, melanoma can also cause hemorrhagic metastasis. So I am going to show you a case which is a CT scan. Unfortunately, I don't have a pre-contrast for this patient, but there are a few learning points on this case. This patient presented with a lot of neurology, and patient was a known case of melanoma. So we did a pre-contrast as well as contrast. I don't have the pre-contrast with me. Having said that, if you see here, there is something happening here, and there is, on a CT scan, there is a bit of leptomeningeal enhancement here. Leptomeningeal enhancement on a CT scan is difficult to pick up than an MR. Then there is some edema here, and one can argue that there is a bit of enhancement in this region also. So these are the findings. Now, on a T2 weighted sequence, you can see a lot of edema, and then you can see edema at other location. Now, concentrate on this region where there was leptomeningeal enhancement on the CT scan, particularly here. And then we go to a flare, and it tells you quite a few things happening right and left, which were not seen on other, sequences. And then we go to a T1. Now, this T1, if you can concentrate on this T1, you can see, look here, there is a deposit sitting here, which is high signal. So this is that melanoma, and then there is surrounding edema. Again here, and here, and again here, and again here. So these are melanoma metastasis, and then on contrast, a lot of enhancement around it, and leptomeningeal and things like that. So this was on a coronal sequence. How does it look like, and how it is going into the various. Now, this is a good one just to develop your eyes, where you can see this leptomeningeal enhancement. Leptomeningeal, another deposit sitting here. So, and on a sagittal, you can see, look at this one. It goes along the gyrus, and then enhancement goes into the subcortical region also. Again, here also. And again here. Okay. So these will be the next sessions. Thursday, 13th August, we start at 5:30 actually, 3.5, and then just Saturday, 15th August, 5 hours. Okay, look at this optic nerve and this optic nerve, and what is your diagnosis?
The optic nerve is seen on the right side, is seen enlarged. I think this is meningioma affecting the optic nerve, because I could see on the coronal images that there is a like a donut sign.
What would you like to do?
I would confirm it with the post-contrast study.
So on post-contrast, there was no enhancement. I don't have post-contrast, but there was no enhancement.
Still, because I could see the optic nerve could delineated, this still could be meningioma.
What else can it be? You know, meningiomas will enhance, right?
Yeah. Glioma is less likely because the optic nerve is seen. Could be sarcoid. Other possibilities.
Okay, thank you. Sorry, I don't have time to give you more cases. I've got 2 more candidates. So thank you very much, candidate 7. Candidate 8, if you can raise your hand. Now, let me do a bit of teaching here. We are candidate 8, are you with us? Okay, candidate 9.
Hello?
Okay. Actually, candidate 8 is also with us, okay?
Yeah.
Okay, candidate 8. Now, I'm going into a teaching mode once again. Now we have started a section. You know, till now what we have covered is just miscellaneous type of things in CNS. It's a mix and match what we covered today. It was a bit of anatomy, it was a bit of signals, it was a bit of sequences on MR. And we have covered, how do you diagnose which kind of sequences in the exam, what are the basic sequences. We did a few differential diagnoses, which were, leptomeningeal or Pecci enhancement, microhemorrhages, siderosis, etc. Now the main curriculum is starting actually. So now we will go, in a more, should I say, structured manner. And the things which we have covered today, they will help you. As I've told you, that the first 2, sessions, I will go slow. So I intentionally went slow today, particularly so that the young generation, the juniors, they can also get something out of it. So now this is where we are starting curriculum. Of course, we will stop today and then we'll continue next time. Now, the teaching point here, we are into phakomatosis. Phakomatosis, if you ask me, what is the most important subject in the FRCR 2B CNS, it's phakomatosis. More cases come from it than anything else. Some of these aren't many cases which, at times they don't like to show nowadays. Having said that, you must know them. Now, phakomatosis, NF1, NF2, von Hippel-Lindau syndrome, tuberous sclerosis, and Sturge-Weber syndrome. There are other things also, but these, the ones which I have mentioned, are extremely important. NF1 is the most important. And in NF1, there is a criteria to diagnose NF1, which we will consider. But in NF1, what happens is that optic nerve glioma, that's one of the prerequisites. The teaching point here on this case was to develop your eyes on a sagittal sequence. This is the optic nerve. This is the optic nerve. If you see this optic nerve is thickened and it is slightly tortuous, and this is straight. They say that even if you see a difference of about 2 millimeter with the clinical context, you can call it an optic nerve glioma. Now, optic nerve glioma is a low-grade tumor. So in a child, it is always low-grade. And if you go back to the basics about brain tumors, please remember that we grade them into grade 1, grade 2, grade 3, grade 4, according to WHO criteria. By the way, this WHO criteria was revised in 2016 with immunohistochemical criteria, which in our practice we don't use it, but we are still sticking with the old concept, grade 1, 2, 3, 4. Now, grade 1 tumors are less malignant, and grade 4 are the worst of, the GBM. There is a concept in CNS tumors of upgradation of a tumor with time. So a tumor can become from grade 1 to grade 2 to grade 3 and then grade 4 over a span of time. Optic nerve gliomas are grade 1 tumors, particularly in children in the context of NF1, but in adults they might be grade 3 or even 4. So grade 1 tumor might not enhance. That's a take-home point. At times they will not enhance. Another thing which can be asked in the exam is this appearance on a coronal sequence, where you can see this optic nerve and you compare it with this optic nerve, and of course it's not completely symmetrical, but this optic nerve is larger as compared to left. It's a subtle finding. This case is a difficult case, but I just put it for teaching purposes. Once you see this, you will pick up more blatant type of cases. Now, phakomatosis has got, this is from your old Chapman, where phakomatosis is, this is the 6th edition, NF1, NF2, tuberous sclerosis, Sturge-Weber, von Hippel-Lindau, hereditary hemorrhagic telangiectasia, etc., and Sturge-Weber. But in the new Chapman, if you go to the second part, you will see. If you go to the second part, you will see, sort of a summary of NF1, etc., and von Hippel, etc. So in the second part, it is given. Actually, if you go into details, then from there you can make long cases where you know that in NF1 what happens in skull versus what happens in abdomen. The examiner might give you a long case out of this. So this is the importance of phakomatosis. Long cases can come in the exam because of that. Okay, now what is the criteria to diagnose NF1? If you open a textbook and see the clinical definition of NF1, they say that if the patient has got 2 or more than 2 of the following, then you call it NF1. And K-Follett spot, 6 or more, 5 millimeter, axillary freckles, Lish nodules, which are iris hematomas, first degree relative with NF1. Look at this. All of this is clinical, nothing to do with radiology, and we are not interested. The clinician will tell us that the patient is suspected NF1. But here we are interested because this is all radiology. So what is in the definition? Neurofibromas, 2 or more than 2, or a plexiform neurofibroma. Then optic nerve glioma is part of the definition. And then distinctive bone dysplasia, which include bare orbits, dural ectasia, and pseudoarthrosis. So with this background, let's see the type of cases which can come in the exam. So candidate, okay, sorry, still in a teaching mode. Optic nerve glioma can occur all the way, it can go all the way to the optic radiations here. So, this is optic nerve, optic chiasma, optic tract, and then it can go all the way, and this you have to understand. Okay, this is a case of NF1, candidate 8. You tell me the findings, please.
There are bilateral thickening of both optic nerves. So sorry, these are T1 sequences.
Yeah, that's fine.
So I've got both coronal and axial cysts, and there's bilateral thickening and kinking of the optic nerve, most prominent on the axial slices through, which makes me suspect that there's bilateral optic nerve gliomas.
Okay, very good. If you see here, on an axial slice, so our examiner is going to show you on axial, right? And you can see this, it goes into the optic chiasma, it goes slightly. Now on this one, if you can see, there is a bit of high signal on this T2. If you compare it here on the post contrast, it goes to the lateral geniculate body, which is next to the thalamus. So the point here which I'm making is that it can go backwards, right? Now look at this case where
Left optic.
so just on this you have picked up this. Very good.
Wow.
Now what?
So it's gone backwards.
So where, anatomy wise, where are we sitting?
That's the so it looks like the basilar, and so you've got the ICAs inferiorly.
Yeah, very good. So the pituitary is here, so we are superior to the pituitary, right?
Yeah.
So means optic chiasma.
Yeah.
Agree?
Yeah.
Now, please remember, they are going to show you here, they are going to begin with axial. And this axial looks tricky, isn't it? That there is a mass here and you cannot make out where is this mass. Basically, if you go back to your anatomy and see this is the midbrain level, so the mass is sitting anterior to that, suprasellar, but here it becomes more obvious that where it is. Now, optic nerve glioma, this type of an optic nerve glioma has been shown in the exam, and my experience is that people have confused it because they have not seen in their clinical practice. So, just 1 second, please. I don't know if I'm able to show it to you, or can you see an image, or you're not able to see anything?
I can just see your files.
No, okay. Now, still no.
Yeah. Yeah.
Okay, this is the type of case which will come in the exam, and which I wanted to show you. Now, if you see here, it looks horrendous, isn't it? That if you see this is pons, and you go into midbrain, and then you see a mass here, and then this is a lot of hydrocephalus. Lot of hydrocephalus is there. So what is happening? Now, this is sagittal. I'm going to skip this intentionally, show you a coronal. Now, if you see here, look at this optic nerve versus this optic nerve. Both of them are so thickened, and this is that optic chiasma. And then you can see that the tumor goes along the optic tracts and on the left side maybe to the radiation. This is a flare sequence which you can see, and then the optic chiasma, and you can see how it goes posteriorly. So if you don't see it, you will be absolutely, what is happening. So that's why I wanted to show it to you. So, supratentorial tumors in children and optic nerve glioma is one of the list. Can you see my PowerPoint now?
Yeah.
Okay, because of time factor, sorry, I got, because there was too much teaching today, I think I could not give enough chance to everybody of you. Can I go to candidate 9 who is still waiting?
Hello.
Okay, now this case, what is happening here, 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 here? The clinical history is that they are worried about NF1.
So there are selected axial MR sequences, and the obvious abnormality is high flare intensity foci located in the right lentiform nucleus in the midbrain and also in the cerebellum bilaterally. In the context of neurofibromatosis, I would be concerned that these represent focal areas of signal intensity, otherwise known as UBOs, unidentified bright objects, which I think are hematomatous lesions. But I would like to assess the rest of the neural axis for features of phakomatosis.
How will you do the scan?
Sorry?
Technique-wise, whole of the neural axis, with contrast, without contrast?
I don't think contrast would be necessary to identify them. I would look on flare supratentorially and T2 in the spine and posterior fossa.
Okay, right. Now, this is a very important concept, and this comes in the exam so often, and a few viva questions which are for the exam in NF cases. What happens is that this finding is seen in many cases of NF, though it is not among the diagnostic criteria. Basically, what you see is that there are high signal within various parts of the brain. Which parts? Anything. For example, brainstem, pons, midbrain, cerebellum, basal ganglia, internal capsule, thalamus, white matter. There can be high signal foci like this in the midbrain, like this in the cerebellum. So previously these were known as UBOs, unidentified bright objects, or unidentified neurofibromatosis objects. Now we call it FASI, which is focal area of signal intensity, FASI in capital. The concept is that these grow in number and size till the age of 10. And after the age of 10, they start decreasing, and they might just vanish when after 20 years or so. The concept is that if they start increasing after the age of 10, we raise the issue of malignant transformation. This also tells you that FACI by definition is not as simple as hematomas. This was one of the concepts, but it's controversial because other people think that this is dysplasia, myelin vacuolization, or with potential of malignant transformation. So if they increase in size and number after 10, or you give contrast, and if they enhance, then you call it malignant transformation. So that will be a glioma then developing. So in the VIVA, whenever you get a case of NF1 or NF2, you must say that I want to scan whole of the neural axis with contrast. Please remember, things like neurofibromas of the spine, etc., you might miss it without contrast. So that's a key point. And the examiner might show you if wants to show anything to you. Another thing is that these patients, as far as FACI is concerned, you want to monitor them. So after the age of 10, usually various people have got their own protocols, but usually 1 year follow-up scans are asked and with contrast for the reason which I have told you. Yes, please. Candidate 9.
We have axial.
So I will, because of time factor, let me tell you the sequences. Flare, T1, and T1, and this is post-contrast T1. So just concentrate here and here. And what do you think is happening?
So in this patient who is a known case of neurofibromatosis, there are bilateral enlargement of the optic nerves, including the chiasmatic region. This does not show contrast enhancement. However, there's a lesion more posteriorly in the paramidline right cerebellum.
That's fine. So this is the type of case you are expecting in the exam, where then you call it that this is malignant transformation. Okay. What about this orbit? Normal, abnormal?
Abnormal.
So what is the abnormality?
I think the abnormality is on the left. I can't see the innominate line, which makes me concerned for sphenoid wing dysplasia.
Yeah. So if you see here, this orbit is larger, and in old books there was a differential diagnosis of enlarged orbit, by the way. This is normal. If you see, this is the innominate line, which is the lesser wing and the greater wing of sphenoid here. You don't see it. And this orbit is enlarged. That line is missing. This is the appearance which is known as candidate 9.
Bare orbit.
Bare orbit, as in naked orbit. So, and this is normal anatomy of what we were considering. And this is normal on a PA film that line is missing here. And this is another case of sphenoid wing dysplasia, where you can see that this is missing. And so, fine. What do you think is happening? We are given the diagnosis.
So there's tibial and fibular pseudoarthrosis formation with lucent lesions of the bone, which I think in NF1 I've classified as non-ossifying fibromas.
So this is a classical appearance of, we have covered this in our MSK module. This is pseudoarthrosis. If you see, look at this in NF1, what happens is that there are bone dysplasias. This can happen in tibia, fibula, humerus. Radius. I've shown you cases. It's an aunt mini type of appearance. Nothing else can show you or can give you this kind of appearance. Of course, post-trauma, etc., is a different world, but post-infection is a different world. Clinically, also, that will be different. So this is bone dysplasia, which can come as a long case also. What is this?
So just on the lateral film, we've got a scoliotic spine with a fixation rod in situ, and there's posterior vertebral scalloping and gross enlargement of the vertebral neural foramen. I think this is consistent with dural ectasia, or possibly a neurally derived tumor causing expansion.
Okay, so this we have done in our MSK module, and the idea was to repeat it or revise it. This is posterior scalloping of vertebral bodies. With this scalloping, there is also scoliosis, and both of these things go together. Posterior scalloping is usually due to dural ectasia. You are absolutely right that there might be some tumor also sitting with it. So this is a case where dural ectasia can be seen incidentally. The take-home point here is that it might be an incidental finding. On a CT scan, if you see it, you are not very, oh, something is happening. Is there a tumor sitting there? You do an MR, and it is just CSF. So this is dural ectasia, and there is no tumor sitting in it. Yes, please. Last 2 or 3 cases, I want to finish NF1.
So we've got coronal, sagittal, and axial MR sequences of a 28-year-old male focused on the lumbar, spine, and pelvis. There is a gross abnormality consisting of lobulated high T2 signal soft tissue, which is surrounding the and expanding the lumbar neural foramina and extending into the adjacent soft tissues. I don't think we have any pre or post, we don't have any post-contrast sequences, but in terms of shape and morphology, I think this is consistent with a plexiform neurofibroma.
Yeah, so plexiform neurofibromas are exam cases, and please remember that plexiform neurofibromas, 10 to 15% in literature, there is malignant transformation. So beware. And last time somebody got it actually with malignant transformation. And so in plexiform neurofibromas, as this film tells you, this is bunch of grape appearance, it's going anywhere. Please also remember that plexiform neurofibromas can also happen in subcutaneous nerves. So a plain film and, a chest x-ray where there will be multiple nodules projecting right and left, and that is a plexiform neurofibroma. In this case, you can see that it is going, it is, speaking itself. There is nothing else. Look here in the subcutaneous fat also, there is plexiform neurofibroma. I've got 2 cases to go, and is candidate 8 still with us? Candidate 8. No. Yes?
Yes, I am.
Okay, because I think I just gave you 1 or 2 cases. So candidate 9, candidate 9, thank you very much. I just want to give last 2 cases to candidate 8. She did not get enough today. So last 2 cases of the day. What is happening here?
So I've got sagittal T2s. There's widening of the
So what's that?
cervical canal and dural ectasia.
Okay. And what is happening
And
here?
on
As
the
in-
coronal, there's kind of expansion with hyperintensity, which is suspicious for a plexiform neurofibroma.
Excellent. So now this is a unifying diagnosis where you pick this up, and you have got your diagnosis. Last case of the day. Yes, please.
Okay, so 50-year-old man, shortness of breath, frontal chest radiograph. There is a mediastinal mass projected over the left apical region. There is so it continues into the thoracic outlet, which intimates that this is a posterior mediastinal of the posterior mediastinal origin, and when comparing the two sides, there is widening or splaying of the rib. So differentials would be a neural tumour that is causing
What will you do next?
In a 50-year-old, I could progress to a CT. If it was a younger patient, I would do an MR.
Okay, so
CT with arterial contrast.
you asked for a CT, I've given you a CT, and I've got an
Thank
MR.
you. Okay, so there is posterior vertebral scalloping, and it confirms that there is a posterior mediastinal mass that is emanating from the left intervertebral foramen, and there's a dumbbell configuration to the soft tissue mass that has kind of scalloped rather than destroyed the bone and the associated bone or the vertebra.
So do you think that there is a mass sitting inside this?
I think this is a neural tumour.
Neural tumor? So means a soft tissue mass? Can you do some technique on a CT scan to confirm that this is?
I could check the Hounsfield units and also contrast from a contrast. Oh, it's already contrast enhanced, isn't it? So it's not. So it could be a cystic, but sometimes you get cysts within.
Okay, so what will you like to do now?
An MRI.
MRI.
Yeah.
So intentionally, I've not given you post-contrast or T1s, etc. But do you see that there is a tumor inside or there is no tumor inside?
No tumor inside there, like
right. So conclusion.
So there's neuron enteric cysts that have caused widening of this.
No, it's the same thing. It's dural.
It's still a neuron.
You see, the point is that this is what we call an abnormal, unusual presentation of the same thing, and that is why I wanted to show you. This is the same thing as, dural ectasia, but this is huge, large. And dural ectasia is also known as pseudomeningocele. There are many teaching or learning points on this film, classical exam film. Now, when you get this kind of a mass, which is posterior mediastinal, now you picked up very well splaying of the ribs. Now, splaying, three things should be remembered. One is what we call ribbon-shaped ribs. Ribbon-shaped ribs are ribs which are dysplastic. So it's an inborn, the shape is not normal. Another concept is splaying. So if you see splaying means the distance between this rib and this rib versus this rib and this rib, and there is splaying means something is sitting in between the two. Third thing, pertinent negative or positive is there any scalloping? Superior rib scalloping and inferior rib scalloping is a differential diagnosis for your chest module. So it can cause this. If you see here, this case, this rib is slightly abnormal in shape. Of course, there is a bit of splaying also. When you compare this with this, the distance is increased. You pick up the mass. Let's go to the CT. Now, on the CT, it tells you what can happen and how. Now, there is posterior scalloping. All of this is scalloped. And you can see on this sagittal how the ribs or this sagittal, on this coronal or this sagittal, how the ribs are splayed, etc. On an MR, it then becomes clear that this is completely cystic and this is simple, we call it lateral meningoceles. This is simple dural ectasia. So the same thing, because it was so big, it was confusing us. And there is scoliosis also.